Hello everyone, this is Prosthodontics on Friday lecture series looking at various aspects of the prosthodontics as well as how to handle various problems. Now this is back to the basics series and we are looking at how to make dentures, and as a first part of the series we are going to look at retention and stability, and today's lecture is Professor Kim Hee-jung of Joseon University. So I know you're very busy with teaching and treating patients, but thank you for joining us despite your busy schedule for this lecture series. I know this is a topic that many are interested in. So could we have first summary of your lecture? Yes, today I'm going to talk about stability and retention of a full denture. So overall, I look at various aspects, how to maintain retention and stability, and latter part is going to focus on what to look after if you have resorption on your hand. Yes, we will look forward to your lecture. So I hope that you will teach a lot of things about how to handle full denture. Yes. Now, if you're joining us through denall, you can leave your questions through this live feed, and you could also have a chance to win a Starbucks coffee coupon through a lucky draw. And there are also other gifts available. So enjoy the lecture and win some gifts also. So we look forward to your active participation, and with that we will get started. So there were video related to today's lecture, so I wanted to show you that first. I think what all patients and dentists want is retention, that results in satisfactory use of full denture. So today I'm going to how to make a denture that sticks on, and this will be the areas that I'm going to cover. So first I'm going to talk about retention and stability of full denture. Now, for efficient use of full denture, you need sufficient stability, retention, and support. So theoretically, these three concepts can be explained, but in the clinical setting, they actually are complementary to each other, maximizing the efficiency of full denture, especially as you have more support and stability, you have better retention, and this maximizes usage of denture, resulting more satisfaction of the patient, hence also to the dentist. So I think that's why we are all interested in how to retain full denture. So what is the adequate retention level? Now, for removable prosthodontics, minimum retention, they say it suffices. But if the retention is too weak, you cannot really chew, and patients feel uncomfortable. But on the other hand, although it's maybe rare case if the denture cannot be removed, or because the patient cannot remove the denture by him or herself because he's not has the physical power, then that is also an issue. So this is from Professor Song Woo-kyo. Actually, 15 years ago, I created full denture for a patient, and on the maxilla and mandible side, the patient could not remove the denture himself and came back to me 2 weeks later, and there were mucosa that was damaged, and that's why I'm emphasizing this fact. Now, what are the then element that increases retention and stability? There are, in the textbook, many you can find, but clinically, what you first need to see is the form of the alveolar ridge. If, as you see on the left, if it's really good like this, then with the sufficient retention, stability, you could have good results on your hand. But as you can see on the second and third photos, if the alveolar ridge is not in good conditions, it's really difficult to have good retention and stability. So it's really hard to keep the full denture in its place. Now, sometimes alveolar ridge is not good, but sometimes you have satisfactory level of retention. But this is, although the alveolar ridge is not good, there are some parts where you can at least secure minimum level retention and stability. That's the reason. So if there is this type of alveolar ridge resorption and you cannot really have good retention or stability, after delivering full denture, it stays on. But after mastication, with the functional pressure being loaded, it cannot be retained, and full denture you probably have experienced come off. So to improve retention and stability, the best way is using implant. And once that problems are solved through implants, you have more likelihood that retention and stability will be in good condition. Next is about saliva. So saliva is also very important element between tissues and full denture. Saliva actually gives the retention power, and as you know, this type of 5 principles are involved. Saliva contributing toward retention, but saliva is not always good for retention, especially if it comes together because it's too sticky, or it moves. Sometimes it shakes the full denture. So adequate level of viscosity is sometimes more important. Next is something that dentists can intervene actively. This is about functional impression. The objective of functional impression is to gain tissue adequacy, and through the border molding, you make the margin and to close it. That is the function of this functional impression, and through this, you could have better retention. But for patient, through functional impression, you have wax denture, and you deliver it on the mouth, but on the right side, it's harmony with the tissues, margin is okay, but on the left, the margin is overextended. So this shows that border molding was not really done very well. So with the fit checker, like this, there is a bit of more pressure pushed down, and that's not really good. So these are the photos I had taken, and shows that even with border molding, for this patient case, on the labial side, you have even with border molding, you have extension on your hand, and this has extracted, and the material is exposed. In other words, overloaded or pressure, and so border molding was not exact. And because of this, this gives you problems on your hand. And this type of bottle molding, you have to make assessment and you make modification before you mix a denture. So through the fit checker or through various things, you check all this different area whether it would fit correctly. So you sometimes say functional impressions or dynamic impression, these steps, but through this, borders and other things can be adjusted, assessed. So again, this is part of the functional impression. So what I'm trying to say is functional impression plays important role in retention. Now on the maxilla side, in the denture delivery step, just before you deliver to the mouth, full denture sometimes comes off. Plastic, there was a fault, or technician in the lab, there was something wrong, so it's not really adhesive. And this, sometimes happens. So don't be embarrassed. Use fit checker, other things to check adequacy and take impression again to recover retention. Next is important thing is forming of the external impression. And this can happen before the denture is complete. And like you see, after the denture is complete, you can also make adjustment. And as you have seen in the wax denture step, using the fit checker and other things, you could create this, or although it's not in the photo, in the wax areas of the wax denture, what is in the gingiva can be removed, and in that area, using the silicone materials, you could take this type of impression, external impression. And even after denture is complete, as I said, using silicone materials and others, you can see where it's too much pressure and make adjustment. So we say this is very neutral adjustment, and you can see whether it's functioning and whether everything is okay. Next is adequate occlusion. So when you see there's adequate occlusal plane and adjustment, and you see whether which is healthy, and based on that, occlusal scheme can be determined. And of course, you have to check the central relations guidance. So again, the focus is making the balanced occlusion, and this is very important for retention of the full denture. Actually, as you can see here, these steps are needed. But before occlusal adjustment, through this you guide the central relations, and after mounting, you check whether it's all okay. And even with the detailed adjustment, you can have this type of contact. But it takes too much time to make it in the orally. So without intervention of the soft tissue, not orally, but on the articulator, you should do this. Immediately after delivery into the mouth, and immediately after occlusal assessment, you see there is difference. Because, as you know, on the articulator, what seems to be unfit, it doesn't really happen exactly like that in the mouth, because soft tissue moves. So even in orally, just because it's mounting finished, don't deliver everything. Again, fine-tune everything again on the odd for the occlusion. So this is very included, making the occlusal adjustment. And how much of the occlusal adjustment do you need to do? She's been wearing a denture for 3 or 4 years, and it's really shaking left to right. But after I have made adjustment, it's no longer shaky. So until you have this type of stability, you have to continuously adjust the occlusion. Next is, actually this is not into the topic, so I'll keep it very short. But as I see, excessive resorption, very hard to have retention or stability, then by using implants, you could regain the retention and stability, and also with one or few attachments, you can increase retention. So I do believe this is could be a good approach. But besides that, what we are also using is denture adhesive and also soft liner. Regular maintenance of the dentures are all also important. And in terms of regular maintenance, realigning and rebasing would be what you do to maintain the retention. So first, in using denture adhesive, this is something I sometimes also use because BMS patients or dental patients, or in case of stroke patients who cannot move jaws by themselves, or in case of those with the tumor on the jaw side, there are challenges. So I used this type of adhesive, but you have to make the patient come back for regular checkup, so that the adhesive stays in place and is in functioning, and it's maintained and retained. Next is when in case of on the maxillar side, where there is a lot of alveolar ridge resorption, as you can see here on the distal side. On the maxillary tuberous, there you cannot really see the ridge. It's too flat, like the ridge is on the level of vestibule. And in such a case, it's really tricky to gain retention. Even if the tissues are good, if there is a bit slight malfunction, the denture can become detached. And in this case, to increase retention, if you extend too much on to the distal side, you go for maximum distal extension. But if the ridge is really bad, excessive distal extension could result in easy detachment of the denture. So you need to have the adequate level. So as you know, the scope of extension is up to R line, AH line. So what we talk about between the anterior and posterior, by giving pressure, you maintain it. So this is the actual patient's case, and with denture. And while speaking, retention becomes weak. So, normal state versus when the patient says I, their air comes free in. There is a bit of problem. So I line is again checked by lining this, and we took photos and adjusted the area. And after this, when I made patient say ah again, there is this type of less gap. So by making it so short, retention actually goes up. And the patient were very also satisfied. This is another case. And for me, I also thought this was very interesting, because this area with the pronunciation of ah, it actually, the person resist fine, there was a loss. So in the beginning, the denture he had with him had maximum extension. When at eye clinic, we thought this was a bit too excessive. But in the beginning, we went with the similar approach. So we tried to control the load, but that was not the answer. So ultimately, what we opt for is through the eye line, like this denture. We formed this through this area, and along the eye line, we created denture, result in actually better retention. So eye line, especially when it comes to maxillar alveolar ridge resorption, even with the small extension or small stimuli, it can be detached. So in such cases, you have to make the right eye line and use that for retention. So again, as you can see here, the distal extension, you stop it where the eye line is, and that seems to be the ideal approach. So second case is creating the adequate border molding. As I say, if the ridge is too resorped, if there's excessive extension, they will be easily detached. But here, the denture is too thick. The border is too thick. And you can see it's not the right approach. Actually, on left and right side, the dentures are the same. But this too, after finishing full denture, through fit checker, we molded to result in this. And as you can see, we molded this area adequately, and it became more harmonized, and there is adequate sealing. And like this, excessive area on the labial side, you see is now adequately changed. The upper side, was too flat, but with the adjustment roundish, there's harmonized result. Of course, this and this of course resulted in better retention. Can I ask you some question? You talked about lines or the border molding, and my opinion, when we think about implant retention, what is important are things we think about. So personally, I do believe that border molding and plaster plus seals are all to improve sealing. So what do you think? I think sealing is important. Well, I do agree on that point too. But I was just mentioning important things, not by priority. But what dentists can do actively is first close the border, because on the maxillar side, posterior fallacy seal, and there's a seal on the buccal side. And for that, you do functional impressions. Through the sealing and tissue adequacy will be secured to increase retention. So that is the primary important to have good retention. So I believe actually when you do border molding on the labial and buccal side, lips, or there's a cheek that you could use, but on the back side, on the palatal side, it's open. Hence, palatal sealing, blocking that, because it's the open area, is important. But sometimes, some dentists, they don't really think about the importance of sealing, and in the posterior or dummy or things, they forget those. But I believe these are very important things to remember. So I hope going forward, a dentist, the postopalatal seal, I believe they need to remember that these are important. Yes, these are very important, but I didn't want to repeat what I said. But again, very important. Clinicians should find this very important, and I believe everybody would be aware of the importance. Well, thank you for that answer. Now we have questions that's been posted in this live streaming of the lecture. There are many questions actually that have been posted. So I think the ID is Kamsik. Yes. So it says, why do you mark the central line on the maxillar side? I think it's a bit off topic to today's lecture. So I think you do this because we have the facial midline here, and plus because of the aesthetic reasons. Now we have answer here. It's because incisive papilla location is stable there. And the question is, if you do excess relief, why does it weaken retention and stability? Well, if you have excess relief, then I think tissue adequacy goes down and there's a lot of space as a result. Yes, some space is okay, but if you have a large space, then saliva or the surface tension cannot work. And also HB9599 asked, the patient had carcinoma of maxillary sinus surgery and their skin graft on the left palatal side. So for this patient, how can I take denture impression? So I think the patient had surgery. Well, if the nasal cavity and the mouth is open, then you can use gauze so that the material does not go into the in there. But if it's not converted to mucosa yet, then you might be at loss. But again, even if it's sealed, even if it's not look like mucosa, you can take the conventional step for impression taking, because after 1 or 1.5 years, it becomes mucosa. So first you see hair, so you are at loss. Yes. So, and the skin graft area, if the surgery area is wide, but the opposite side is okay, then implant placement could also be an answer. And the question is, dentures are mostly for elderly patients, and they typically suffer from xerostomia or have more saliva viscosity and feel dentures uncomfortable. So do you use artificial saliva, or do you treat the xerostomia, or what kind of approach do you take? Well, personally, artificial saliva or not drinking water but wetting the mouth is my recommendation, because the drugs for xerostomia, pilocarpine, others stimulate parasympathetic nerve, but it does not only secrete saliva but also other things, so it's not something you can use very easily. So rather than approaching with drugs, wetting your mouth with water or using artificial saliva are my recommendation. But if severe dry mouth and there's a BMS symptom, so denture cannot go in, then we also have soft liners these days. So because it's very hard to maintain mouth condition in optimal way. So for dementia patient that you have seen already, or you suffer from malfunction and cannot really control your mastications, then using the soft liner might be an option and can be effective. Now, dry mouth, then artificial saliva are sometimes used, or drops. So those that feel a bit acid in taste stimulate secretion of saliva. So that could be an option. And then icon 1085 says green wax that you use for the central relations guidance. Why did you use that? That's LOX, as you know, and LOX has a low softening point. So even if you take good impressions and you have taken the relations very well, but there could be premature contact. So one air comes into contact first and the other side later on, and both are in contact, and you might say it's happening together. No, probably because of the elasticity of the soft tissue, there are premature contact that you might have not thought of. So you have to be aware of that and to secure good relationship. In other words, when you take the jaw relationship, loading simultaneously on both sides, you use wax. So in guiding CR, they have simultaneous mucosal loading. And another said there should be some training for the tongue require. Well, that I think it will be a lecture later on. Now I want to know the steps you take for the occlusal assessment. You do it big and then fine tune it later on. So what kind of device and material do you use in which steps, and how much does it take chair side? So time depends probably on the case. Now the steps for occlusal assessment. The central relationship is the most important one, whether do it in the articulator or in the mouth. As you know, central relationship is the most important that you cannot really do on the lateral side, and given that 70% central relations determines the result. So if that is okay, then retention becomes better. So first central line, and so even if the central relations is good, patient find it 70% satisfactory, and then you have thick or both different colored check bites, what I use. And chair side time-wise, clinical remounting takes about 15 to 30 minutes of time, and if it's really not fitting, then 30 minutes. So on average 15 minutes. So in the mouth, orally, if it's not really a fit and trying to have it fit, or if there's no support or stability, the occlusal adjustment really takes time. It becomes really unpredictable how long it's going to take. It could take an hour or something, 30 minutes. And then another question, because of the irregular residual alveolar ridge, if you do undercut and because of the you do block out relief, it could hinder retention. So how much do you allow for the relief and block out? Well, that's a bit vague question. Well, you have to make a clinical decision. Like there is an undercut, so in the insertion that happens vertically, there is a hindrance, then you have to remove it. But if you do an angle and one side first and the other side later, sometimes it's resolved. So consider all that. But in most cases, if there is a hindrance, then the gingiva, the patient complain of pain and there could be bleeding. So until that is resolved, you have to do a relief. So you put it in and out, and you see how much the patient can endure. And there are other questions, but I believe there's a lecture remaining. So we will hear your lecture first and then continue with the Q&A. So thank you for all the questions and your comments. And we look forward to your continuing participation through asking questions. And as I said before, we'll have lucky draw of those that pose questions, and you can win various prizes, including coffee coupon. So let's look at where there's a lot of rich resorption on the mandibular side. So there's even convexity, so there's a lot of severe ridge resorption, and a radiograph shows that ridge is really fragile. And actually for this type of patients, retention and securing retention and support or stability is not easy. But when you have this type of patient, to find the right treatment strategy, what you need to do is, can there be sufficient support? Even if there's that type of bad conditions, and can there be stability that can be secured? Because support and stability all needs to be there for the denture to be maintained. Without that, even if you make all your efforts, retention or stability would not be there. So first, for this type of patient, you have to think, when I create full denture, can I gain stability, and whether there could be like horizontal and equal stability and support. And so if there's no stability and support that you can secure, then you have to use implant. Even if it's a full denture, for this type of patient, continuous to gain continuous retention for this type of patient, you need to place implant. Otherwise, it will be very tricky. So you have secure support and stability through implant placement, or even without stability support. Then is there a way just to increase retention? So for this severely resorbed ridge, what would be needed? It's same as in the maxillar side. It's very sensitive area. So even if it's a slight extension, there could be problem. So you have to be really cautious in forming the surface. Like first, let's look at the border molding first. Same as before. Like here, you have a bit push here. Then after the full denture has been corrected and completed, then lightly, if it's there should be elevation. Otherwise, you have to find the right position. But generally, if there's a rebound of denture, then is it because the labial is too long or the lingual is too long? It's very hard to tell. So as you delivered the denture, sometimes you have immediate rebound. And for me, as you can see here, I first the bottom frame and other area toward the outside, I stretch the tissue and then deliver denture. In other words, the load that can go in on the side can be eliminated and see whether there is a rebound. And if the denture goes up, that means on the lingual side there is overextension. If you did this, but there's no lift. But if you take your hands out, there's a lift or rebound, then there's a labial side overextension. So fit checker, rather than that, you check through this approach to see where there's overextension. That is the best way to find the problem area. So this denture, after it's been complete, using fit checker, the border has been adjusted and complete. So the thickness on the lingual and labial side, you see, has become thinner. Then the retention has become weaker? No. As I've talked about the case early on, the photo you have seen is actually these ones. So in terms of retention, there's no change. Hence, even visually, if it's too thick area, then even horizontally using fit checker, you have to make adjustment. And here, it's adjusted result. So, lingual or the labial areas, you see have become thinner, and you see it's much better functionally. So for this case, we have laboratory conditions to make it, but we had a lot of adjustment to make it harmonized. And next is about adjusting the surface area. We scanned here and tongue, and also on the side. So because tongue on the lingual side, it's pushing down, so it's close. So this is for the severely resorbed patient. This is very important because of these conditions. So depending on how the surface area is, it can improve the retention. So you believe BTC and other concept you would know how to do that, but tissue condition fit checker can be used to make assessment of the surface, and that would let you know how good closing and sealing or the opening is there. So the denture can reduce the tissues with tongue, not too excessively, and having that surface is the goal. So the position of the tongue is the lateral border of the tongue. Apologies. The lateral border of the tongue on the occlusal plane. It should be up on the occlusal plane, and the anterior side, the tip of the tongue, like this, on the lingual side. So the mouth floor should not be exposed or slightly touching the tip of the tongue. So it's favorable for the tongue in maintaining the mandibular in position. So then actually when you looked at which area should be thin and which area needs to be adjusted, then this is before making adjustment. Again, on these areas, tissue conditions have been marked with fit checker, or with fit checker we took the photos, and if it's the tongue is really pushing down, and if there's even hole in the check bites, so the materials there has been holes, and this is because of the excessive load coming from the tongue. And after making adjustment in this area, then you see more consistent regular silicone cover. Same here on the lingual side and all on the surface areas. With the tongue, the area that touching the tongue, you have to make assessment. So eliminate their area that come into excessive contact, and then the areas become thinner and better. So this, as you see, overall, there's a similar in thickness. Hence, in fit checker, the tissue adequacy and the border length is what you look, but even the surface area should also be looked at and photographed, and through that you can gain more information. And on the butt, on the cheek and other areas, you can check whether I did adequately, with whether it's seating well with the surrounding tissues. And this is after making it. It's really thick, and there was clear line with the thick area, but it has become concave, molded, and thinner, and will sit well. So it's much better in terms of stability, or there's no change. And if it's too thin, you would want concern that it will not be retained well, but that is not so. If it's sitting more comfortably, then it's actually sit well with the tongue floor. So sometimes this becomes as a vestigial organ, the fold. So sometimes, but it's concave, convexed. Then even the retraction of tongue like this, the lingual fold is there to create sealing. So the retention and the closeness is something you need to check. So you have to see where the lingual fold situation is there, and if you leverage that, it's better to maintain retention. So here, if it's not excessively pushing, but regularly, consistently, not focused on some position. So having that consistency or the same level is very important. So if there's a less lingual fold and the tongue is retracting, then sealing breaks. Even then border molding and other things, you need to be cautious and exert efforts to correct the situations. Next is with the tongue, you can maintain the denture in the position. Tongue, even in the normal position, can help maintain the position of the denture. So this is a favorable position. But tongue is not only staying at its normal position, as in this paper by Wright. So mouth floor is not exposed, then you say it's a normal position. That was the precondition of this paper, and they say 65% was in that definition of normal position, but this was for natural teeth. But normal position is even 35% for natural teeth. So if the sealing on the lingual side breaks if the tongue is too backside. And then there's a Japanese paper, and here says same concept. If there is a dention, then normal is close to 90% in terms of normal position of the tongue. But for the partial edentulous and complete edentrance, you see the positions is less than 40% in terms of being normal position. This shows that if residual teeth, as there is fewer of them, normal position of the tongue becomes harder. This shows that with the teeth and tongue touching the teeth maybe is the way to find the right position. That's what I found reading this article. But anyways, we know the importance of tongue, but we don't really know how to use it. Not only dentists, but sometimes a patient do not feel senses of the tongue. So there is even paper how to train a patient to use the tongue. And as you know, and the convex area, create something convex on the lower jaw, or if you create some holes, convex, concave area, convex or convex area, the tongue will go there. So putting that in the anterior side helps train patients. So training a patient, you have to let a patient repeat it. So even 2 or 3 times a day, you ask the patient to move the tongues up, down, left, right. This is way to make tongue stronger and put it into more forward position. Even to increase sensitivity of the tongue, this is needed. So basically, moving the tongue, training for that is needed, especially if you're wearing denture. Another thing is that in terms of if you use denture and tongue pushing down on this side, on the anterior side, the tongue tip, and it would be good. But that sometimes does not happen. So even you have to train the patient. You have anterior to use chewing, and sometimes they most use premolar. It's like, you know, having a tomato or peanuts, they use premolars on the backside. But rather than doing that, like this, tongues, if they use even in denture, don't let it slip. You know, sufficiently there is a resistance so that there will be support. And the tongue tip on the mandibular side needs to push here down to make full functional use of denture. So you have to explain all this to the patient and let them exercise. And once they make this into habit, it's better in terms of functions and denture positioning. So in summary, actually, in terms of retention and stability for dentists, besides the patient's existing conditions, border, molding, closing, and you need to look at really whether there is a functional impression. And then you need to harmonize with the surrounding tissues. And when they function in the mouth, there should be harmony with the occlusion to have sustainable stability and retention. So this means you have to find causes for delivering this and make continuous improvement to get into good results. Thank you for the lecture. So then we'll continue with the Q&A session, which we stopped beforehand. There have been also additional questions that have been posted. So we will look at the live chat box to answer some questions. OHS asks, regular maintenance would depend on case and would be different by case, but where would you focus on? So what's your focus, I guess, in recall check? Very similar to the topic of today. It's all about retention and stability. And I think patients feel first. I mean, they say it's become loose or it's painful. So that actually becomes indication for relining. So the principle for relining is also the same. Through relining, you get the fitness and you get the sealing on the border side, and then you complete occlusion. So rather than where to focus, all these things. So ultimately, the maintenance is about the creating good border molding and having a good occlusion. That's how to improve function. So you first check whether there is a retention, any change in the occlusion. So, you know, what is the chief complaint of the patient? I think probably that is the focus. Light asked, especially on the mandibular, if there is a bone cast on the lingual side, how much of the length of the border area do you allow by cutting it? I think torus members is what he's referring to. Well, actually, mucosa, if it's fibrosis and it's hard, then that area, even with relief, there's not much of discomfort. But if the cause is really big, or mucosa is not healthy, that is remaining, then it could act as a stimulus, and it could also move around left to right. So if there is a excess, it's better to cut them. Yes, it's better to cut. But patient cannot mentally handle it, or has difficulty in movement, then if you pick that whole area, but it's not easy to do. If it exists and if you do piggy, it's really difficult. So if it's that might, but at least an option, but very short, putting it on top of it. So yes, there is a possibility of lack of retention and stability. So textbook approach, if it's big, it's better to remove. So Ilpyeon said, if you use adhesive, sometimes you have inflammation. Any reason for inflammation? Well, in case of adhesive, actually by itself, maybe it's sensitive toxicity, but in most cases, it's because you cannot fully remove the adhesive. So patients, if they wear the denture for too long, then there's a lot of load in that area. You have to, rest the mucosa, but that was not happening and resulting in inflammation. Or another reason could be, I couldn't find the photo for today's lecture, but 5 years ago I had this patient. He loved the denture adhesive, and it seems that the occlusion of the denture horizontally and vertically, compared to the midline that I had in mind, it veered away too much. So denture itself become a stimuli because the tissue changed too much. And because of that, if there is excessive tissue change and you continue to use it, sometimes you get inflammation because there is too much of a stimuli. And with the resin polishing, you could create smooth surface, but adhesive, the surface is compared to resin, the food can stick, and you have this result, and maybe that contributes to inflammation. And the next question from DBDIP 007 says, in case, what is the average intercondylar distance? Well, I think it's not really related to this lecture, or maybe 100 to 110. So yes, between 1 and 100 is the standard setting. And then next question is functional impression using tissue conditioner. If there's a lot of resorption on the rich side, is it really helpful? Well, strength of the tissue conditioner is that selective impression or whatever, due to the properties of the material, if there's an excessive resorption of the alveolar ridge, you cannot fully take the impression, and whether it's a PAVE or open mouth technique, whatever the technique in function, you don't take impression of mucosa level, so there is a limitation. So tissue conditioner, there's a dynamic impression. So actually, you let it function half a day, and in the functional mucosal, that tissue and deformation, if you see that, then more cohesive load is put and there's sealing. So I think that would be helpful. Okay. And next is 231231, the created denture using silicone. If you take a functional impression, wouldn't it result in increase of VD? Well, so your answer? Actually, in silicone, well, pitch checker or PVS and this type of silicone and other silicones, it's not really that high. In most cases, it's light body viscosity, or that level of viscosity. So if you actually let it fit, the micro level, it's thickness. So in occlusal adjustment, it can sufficiently offset. So you shouldn't be too concerned about that. Next is OUTSKHK says on the upper denture in occlusion, there is consistency and cohesionness on the check mud, but complains that the patient cannot be chewed. So what is the problem? So, and also it says retention is good. So what it would be the reason? Now opposing teeth could be natural teeth. Maybe not is the case, but anyway, in such a case, ultimately, it's an issue of occlusion. Hence, what you need to check is because the check bite kotsu doesn't mean it's good. With the Weller wax, take impression as I did. So here you have to have accurate occlusion assessment, and as our professor said, the occlusions, if there's what is the tension and whether it can break the food. So where is the function? So maybe also if first time wearing denture and cannot chew, then maybe it's not really know the limits of the denture and think it's the same as a natural teeth. So you have to tailor the resolution by patient. But in case if there's any remaining natural teeth, the occlusal plane can be too liberal or leaving. It could move. So it's sometimes not efficient to get good mastication. And then we have Parkinson's disease or alcohol abuse. So environmentally, the patient's moving jaws. So in creating upper denture for this type of patient, anything to consider. Now jaw keeps moving. So rather, maybe lower jaw might be more tricky than the maxillary side. I think if it's a dementia patients or Parkinson patients, due to the medicine they take, sometimes the load in chewing is put on too excessively. So retention-wise, without implant, you cannot guarantee it. And for this type patient, the bigger problem is that specific area continuous load sometimes result in bone necrosis. So for this patient, mucosa area not maintained well, so the caregiver needs to clean the denture regularly and let the mucosa rest. But if you don't take care of it, the dentures, then you have serious issues on your hand. So I think maybe I opt for tensile bond for this type of patient. Yes, next question. If there's a lot of flabby tissue, how can you increase maintenance and stability of denture? So when you take impression, combination intermission, you're talking about not moving the flabby tissue? Yes. So using the pressurized impression taking so that and try to retain it. Anything else? Maybe removing the flap tissue as the first step would be, yes, removal, it would be good. And if that cannot be, then flabby tissue, there is a load that can go in. And without anterior ridge, there's no stability. So in such a case, maybe on the posterior side, placing implant could be an option. And then next question is, when you adjust the margin of the border of denture between PIP and fit checker, which do you prefer? I don't think we have seen much of the PIP today. Yes, I do use PIP, but personally I like fit checker because you can see everything at once, fitness and the margins, and you can even check the polished surface area also. So I prefer fit checker. And Ina said you look very good on camera. and says I'm not giving you a praise because I want coffee coupon. So, but anyway, next question says, which kind of functional impression material do you prefer? Well, for me, PVS or rubber materials. So that is the first I use. But if it's a challenging case tissue conditioner or fit checker, are used to use dynamic impression taking. And then palatal seed area, how do you apply that? I think vibrating line is what you use. Probably you have already explained. And then you have, even if you obtain vertical dimension, there is a difference between the dentures oculation status and the oral situation. So maybe there is a vertical dimension lecture later on. So the professor that's going to talk about it can answer your question. And there is a lot of inflammation in the oral mucosa. So if you use tissue conditioner, which one do you use, and do you use that for denture making? Well, the inflammation pain goes away within a week usually, but if there's a laceration or epiphyseal or serious cases, in other words, then about a month is something that you have to keep follow up. And then hesitated is the idea. Says a lower full denture when the median area does not seal well. Any tips for the border molding? So yes, the midline or the central area, I think, is what he's talking about. Nothing really particular, but as you can see in the literature, using pronunciation, or there are different textbook approaches that you can use. And for me, actually, if cannot seal on the anterior side, it also relates to the positioning of the tongue. So maybe improving position of tongue is what you need to consider. So even after making the denture, the tongue positioning through communication with the patient, or maybe have a convex or concave of the denture, so that that patient will draw into that area in terms of positioning. So if you have older denture, then you train the tongue and then take maybe impression, could be also an option. And then another question, creating denture with scanner, do you use that? It seems in case of edentulous, adjustment scan, and tongue can be scanned. I mean, setting neutral zone would be possible, or is it too advanced in terms of thoughts? Well, we have another lecture, I guess, here, but do you have any opinion on that? Actually, scanner, as you know, for static area, you take image, so you overlap image to get the whole image. This means that for edentulous on the mandibular side, you scanned it, and to recreate neutral zone, I think it's not easy. So on occlusion or denture like scanner, if that becomes available, so if we can sense that area as a one-stop solution, maybe that could be something as a technology that can be available in the future. And then the tongue has become big and flat because it had a long edentulous period, cannot really wear denture, cannot pronounce very well even after 3 months, so wears only denture during meal time. Or did I go too much internally in my alignment, or how should I solve these issues. Maybe there is a lecture on complication later on. So, but anyway, you can talk about this too. If the pronunciation is not clear, and well, I think he can have meals, but if he cannot have a clear pronunciations, then maybe tongue position assessment would be most important. So tissue conditioner or fit checker could be used to see how much labial it's leaning the tongue. And there are people with a very big tongue, then maybe shifting the position of denture could be a way. Yes, patient also need to make efforts, in my opinion, because in most cases, denture, if delivered in the orally, very different than using natural teeth. So you have to accustom yourself. So by reading newspapers and self-consciously trying it, there could be improvement in pronunciation. So if you can chew with denture, I think pronunciation would be easier. So usually you get accustomed within a month. So you have to work on it. And then on the labial and buccal flange, patients sometimes complain of food retention. So why is this and what would be the solution? In most cases, the buccal and orbicular oris muscle area cannot push food toward the occlusal plane. This means excessive, the border is too short, or the border is weak, it's too concave, or it's too excessive. So not adequate border formation and surface formation probably are the reasons. Okay, then next question is internal fitness and occlusion of the denture. What needs to be checked first? If it's old denture, then fitness is something you look at first, and whether it's okay, and then you look at occlusion. So denture occlusion is important. So occlusion is not always the first thing. First, if it's fitness and support is really good, then you could check the occlusion status. And it says, thank you for a good lecture. It says, I love this lecture series. And says also, thank you for all your answers. Now, with that, I think we finished all the Q&A. Sometimes we could not finish answering all the questions, but thanks to your, good answers, we're able to finish today. And thank you for all the questions. So now we will pick best question of all the questions that's been posed today. So you have to choose the best question. One, I should choose best one. So the ID 할 수 있다 would be my best question. Oh yes, I see that. Okay, ID 할 수 있다, you've been chosen as the best question of today's lecture. Congratulations. So we will contact you and send you a prize. And those that won coffee coupons, you will get a text message on Monday. And don't be disappointed. Friday lecture series continues, and there will be also live chat box that will be always available. So if you continue posting questions, you'll be able to win the lucky draw. So we look forward to your active participation. So thank you very much for today's lecture. So any final words to your colleagues or seniors or juniors that you want to leave with? Well, actually, in denture, creating denture is also tricky, but maintenance is also tough. After delivering, then having the denture, there could be a lot of different complications. So they say with heart you can see. That means that if the patient feels some discomfort, then you have to try to resolve it, and you empathize with the patient. So if you continue to make effort, so you have to yes, empathize with the patient, and not only will upgrade the skill as dentist, the patient will trust you and result in good high quality treatment. Well, thank you very much for that wonderful lecture. So with that, we would like to end today's lecture. I hope you enjoy this. So we looked at today try to share with you various tips on making and retention of the denture. So if you have any questions, please visit our website. But I think we have answered all your questions. But anyway, next lecture will continue in the denture series, and we'll talk about BPS with Dr. Lee Hoon-jae. See you next time. Thank you very much. Thank you so much.